No one's excited about antibiotics again. That's okay. That's all right. We'll get you excited about it again. Now we're talking about it from the pulm standpoint. It's okay. You're gonna find that a lot of this has some bleed over from the ENT stuff, because again, a lot of like upper respiratory tract infections that kind of develop into these more lower respiratory tract infections. You're gonna see a lot of bleed over the same bugs, right? So what kind of bugs do you think about with ENT stuff? Strep pneumo, Marcella catarrhalis, H flu, right? I had one class that said shake my head. That was their way of remembering it. So SMH. So I don't know if that helps you remember that. I don't know. That'd be some way. Anyway, I asked them, like, what's the most common bugs? And they go, shake my head. And I was like, what? What are you talking? And then I was shaking my head, so I guess that worked. But no, it's yeah, strep pneumo, Marcella, and H flu in that case there. Anyway, so bronchitis, again, this is a inflammation of the actual bronchioles. I'm sorry, not the bronchioles, but the kind of larger airways here. Again, what is the most common cause for this typically? Viral, right? So again, this is one of those things where a lot of people come in and they say, I got bronchitis. They want to get treated with a Z-Pak. We'll find it's not always going to be the case, right? It's not always going to be great. You know, this is more acute bronchitis we're going to be talking about. We'll talk about COPD a little bit later on, to thinking more like acute chronic bronchitis there. But commonly, as we mentioned, things like rhinoviruses, adenoviruses, etc., are going to be the big causes here. Occasionally, it's going to be bacterial. Now, if you look at the bugs most commonly seen here is where you're going to notice a lot of atypical bugs. You have things like mycoplasma, pneumonia, chlamydia, bordetella, things like that. And then you have the typical sort of upper respiratory tract stuff like, you know, the H flu, Streptococcus, things like that. Oftentimes what you end up finding is the patients will start off with a viral illness and then will develop into a more bacterial illness. So if you see it kind of going on for a longer period of time, that's what you can start to think about. And sometimes these patients, you may prescribe them and say, hey, I'm going to give you a prescription for a Z-Pak, but don't start it just yet. If you don't improve over the next couple of days and it appears to be more bacterial, then you want to go ahead and go fill it. Of course, what a lot of those patients go do anyway, they just go fill it because I want to feel better now. And then by the time the Z-Pak kicks in, it's like, well, the virus is clearing anyway, and they would have gotten better regardless. So, but that is what sometimes people will do, is they'll say, hey, just don't feel this yet until, you know, a couple days go by. Anywho, as I mentioned, typically self-limited. You can treat this with simple over-the-counter analgesics such as acetaminophen, ibuprofen. Good, it's good for antipyretic effects, right? Both of those could be used for that. Antitussives like dextromethorphan. Remember, benzonatate is a prescription only, so I would not count in that case there. What would guaifenesin be used for? That's an expectorant, right? So it's not, again, it's not an antitussive agent. It's going to help you get up into that mucus and stuff you got kind of brewing there, right? Obviously, fluids, make sure you keep the patients nice and hydrated as well. Now, typically what we don't like to do is use antihistamines or decongestants, like things like pseudoephedrine. That typically is going to decrease secretions and kind of make that stuff more tenacious and harder to clear, and then may actually prolong symptoms for a bit there, right? Remember, first generation antihistamines are very drying, and then the the sympathomimetics are going to squeeze down those blood vessels and can again dry it out as well. As I mentioned, the routine antibiotics are not recommended. However, symptoms are going to be more prolonged, say greater than 5 days. That's where you want to start to consider more bacterial involvement. This is where things like trying to gear our treatment more towards the atypicals is going to be more appropriate here, right? As opposed to something like trying to think of something else we covered. We'll talk about pneumonias a little bit later in regards to like when we're going to be covering for atypicals versus some of the other stuff. But here we're thinking more atypicals, right? So this is where doxycycline could be a good one. This is actually preferred if you especially have a lot of documented resistance towards the macrolides, which we know is a problem because a lot of people just prescribe a Z-Pak, and so you see that resistance developing here. So doxy can be really good. Who is doxy not good for? Kids less than 8. Pregnant women, second and third trimester especially, right? So those would be ones you want to avoid there, right? So in the macrolides, we'll get those atypicals as well. So azithromycin, erythro, doesn't really matter. Azithro is probably the most common one, far and away, followed by clarithromycin. And then potentially, if you could not use one of those, you could always get away with using a respiratory fluoroquinolone. And when I say that, what does that mean? Moxifloxacin would count. Levofloxacin would count. What about Cipro? Why not? It could be used for like stomach stuff, but the main reason why we don't consider Cipro to be a respiratory fluoroquinolone is because it has pretty shoddy coverage against strep pneumo. You see a lot of resistance to Cipro against strep pneumo, so because of that, it's not going to be reliable enough to be used for a lot of these respiratory conditions by itself. Okay, does that mean you can never use Cipro for lung coverage? Doesn't mean never, right? It just means that typically it's not going to be good for empiric coverage, okay? So levofloxacin can be used, moxie can be used. Those would be totally fine in these cases here. However, remember, we like to hold those back if we can and utilize something like a doxycycline, use something like an azithromycin if need be. Okay. Moving on from that, getting into community-acquired pneumonia, it's a good kind of bleed over into that. Remember, why did we develop? Normally we think of the lungs as kind of being a sterile environment here. Reasons why we get some of these bacteria spreading into the lungs themselves to cause pneumonia, it could be things like microaspirations. We see this a lot in more elderly patients, especially, what do you think are some things that kind of predispose them to that? It's aspirations of bugs into the respiratory tract. Could be related to things like, mental status, again, so if they're not really protecting their airway very well due to depressed mental status, like, dementia, Alzheimer's, things like Parkinson's, especially. Also think about the medications they happen to be on. If they're on a lot of like CNS depressants, if they're on things that are affecting their mentation, that could also be a big reason why they're not really protecting their airway enough, and that way you can get some of that little microaspirations occurring there. Why it tends to be more common in the elderly. Certainly, if you have things like hematogenous spread, that can be a big thing. Or if you could potentially have like direct inoculation, think about traumas. We'll talk about healthcare-acquired pneumonia a little bit later, but anytime you're introducing anything foreign into the respiratory tract, is we're going to see potential for infection. So, looking at our diagnosis, as far as how we're going to manage this. On the outpatient side, and again, your question is like, are they sick, not sick? Where do I need to manage these patients at? And so, how do you decide if you need to admit them or not? There's a lot of scales that are out there, especially with like pneumonia, because it is such a relatively common thing. It's one of those things, there's scales that are out there to kind of help you dictate, okay, well, how sick is this person? They go to ICU? Do they just go to the floor? Again, I'm not going to get super into that, but I'm just going to talk about how we're actually going to manage these, because depending on how sick they're presenting, whether they need to go home or go to the hospital, is one of those things where it can kind of show you, okay, well, what bugs do I think are going to be most likely associated with this, okay? And that's going to dictate what your coverage is going to be from an antibiotic standpoint, okay? So typically for outpatient management, if you can send the patient home, they look well enough, empiric antibiotics are going to be totally fine. Do I need to culture those? Typically no, right? So again, if otherwise relatively healthy individual, no comorbid conditions, and you're looking fine, you don't really need to do a whole lot, right? However, if they need to be hospitalized, they probably want to get cultures here, right? Not only do you want to get a sputum culture, what else do you need? Where could those bacteria have come from? The blood, right? So potentially you want to get blood cultures as well, right? How many blood cultures do you get? Yeah, at least 2 from 2 different sites, or 1 from 2 different sites. That way you make sure you don't have skin contamination, right? Something comes back staph epi, it's probably contaminant, all right? So, and again, when do you want to take those cultures? Before the antibiotics, because otherwise you may not culture anything out, and you think, well, it's either not bacterial or something else. Maybe it's fungal, maybe it's anaerobic. I have no idea. Could have been just been that you gave the antibiotics before the culture was performed there. Now, again, when you're doing a sputum, gram stain, and culture, what are some of the problems with that? Yeah, we're getting the sputum from. Is it just spit? Like if you get it, there's a lot of epithelial cells. Like it's probably not actually really representative of what's truly deep down there in the lungs. Now, again, I could do something like a bronchoalveolar lavage and really get deep down in there, but that usually requires intubating the patient. Again, if they're not that sick, you probably don't need to get down. But at least a sputum culture can give you some idea. But a lot of contamination you just want to be aware of. Okay, you may not always be getting the responsible pathogen actually be culturing out from that standpoint. So if you're thinking more outpatient etiologies here, you're going to be thinking things like strep pneumo, mycoplasma, H. flu, Moraxella catarrhalis, and then a lot of viruses, right? So you're kind of familiar with looking at that set of bugs there. As you get more into the sicker patients requiring admission, maybe requiring ICU stay, what do you kind of notice starting to pop up? Things like Legionella, right? Is we're going to start to see more things like, Staph aureus is going to be a potential concern here. Things like gram-negative bacilli potentially are going to be popping up, especially in those more sick patients. So again, your coverage as far as antibiotics go need to kind of step up their game as you get in these sicker and sicker patients, right? Because again, we're starting off with empiric therapy. We may not know what we're dealing with right off the bat. So you kind of have to go broad. And then what do we do once our cultures come back? You narrow it down, right? And you narrow your spectrum to make sure you get as narrow coverage as possible to hopefully try to curb resistance, right? And then also toxicity to the patient. So looking at things that may make them, potentially at risk for specific pathogens. So for instance, like strep pneumo, we'll look at their age, right? They're older, typically they're more susceptible to this. Another big thing to note is what have they been on previously? Have they been on a beta-lactam in the past 3 months? That puts them at greater risk for having a more resistant strain of something like strep pneumo. Okay, that may lead you to say, hey, I need a bigger gun here than if they had no antibiotics in the preceding 3 months. Okay, things like alcoholism, immunocompromisation, any of those make them more susceptible to some of these bugs that a normally healthy, functioning immune system can normally fight off a little bit better. Okay, so again, also exposure to kids in daycare. Why do you think that's a problem? There's cesspools of disease and bacteria and the cooties. They just get back and forth to each other, and all of them are on antibiotics. Again, the super bug that kills off humanity likely to come from there, right? Some sort of daycare. We can go back to Patient Zero. Everyone see that movie? It was like Gwyneth Paltrow. What was it called? Contagion or something like that. Something like that. And they kept going back and back to see where it originally came from. Actually, it's going to go back to a daycare, I guarantee you. Watch. Anyway. And go back to someone inappropriately prescribing like a Z-Pak form or something. But again, so if you have that exposure, right? So if you have grandmas, taking care of the kids at home on the weekends, kids normally in daycare during the week, that could again give you a sign that, hey, maybe they have more resistant bugs that we're worried about here. So other things like Gram-negatives, they're residing in a nursing home because, again, they're going to be around a lot of other people who have chronic conditions that could be spreading their bugs around. Any kind of comorbid conditions, underlying respiratory disease, anything, things like that. And, again, recent antibiotic use. So, again, you have to ask, what have they been on recently? You may not have good access to that, but you can at least ask family members, ask people at the nursing home, wherever they're coming from, like try to get an idea of what have they been on recently. And then specifically with Pseudomonas, if they have structural lung disease that's putting them at risk. If they've been on corticosteroids, why do you think that puts them at risk? They're immunosuppressants, right? Good. If they've been on broad spectrum antibiotic therapy, right? So if they've just had a course of, being on levofloxacin recently, that can put them at risk, especially greater than 7 days in the past month or so. And then also malnutrition. Again, that's going to have a negative effect on their ability to fight off infection. So looking at this, they have no risk for resistant strep pneumo, that we can get away with something like with a macrolide here, right? So something like azithromycin and clarithromycin, those would be totally fine there because, again, those should be able to get that strep pneumo if you're not really worried about it being too resistant there. On the other hand, something like doxycycline, minocycline can be used as a good backup agent in those cases there, okay? They do have risk factors for resistant strep pneumo. This is where a beta-lactam plus a macrolide can be utilized together, right? So a beta-lactam meaning what? Amoxicillin, cephalosporin, something that's going to be able to get that strep pneumo, and then you will then have the macrolides to get the atypicals. Right? Because remember, a lot of those beta-lactams do not have good atypical coverage. That's why I like to mix these two together. So for instance, we have cefuroxime, cefpodoxime plus azithromycin, or you could do like, say, augmentin plus doxycycline or something like that. You get that combination therapy in order to get that strep pneumo plus any atypical bugs that might be there. Or potentially, you could use something like a respiratory fluoroquinolone. As I mentioned, levo, moxifloxacin should be able to get that strep pneumo and be able to get those atypicals. But again, try to hold back on those if you can because resistance is such a big issue there. Or if they can't tolerate beta-lactam due to allergies, this is where fluoroquinolone can be good as well. Okay. All right, is everyone ready for more pharma fun? We put the pH in fun, maybe? No? Anyway, let's continue on. If you guys stick with me at the next break, I'll tell you one of my favorite jokes of all time. It has one curse word in it, though, so I don't want you guys to be prepared for that. It goes a little blue, a little blue. Anyway, so at least that's something to look forward to. It's not the F word, so don't worry about that. Anyway, so any questions from the first half? Let's bring it in. Sun's going down. Remember that from Thor Ragnarok? Anyway, you guys don't watch movies, I understand. That's fine. Toddlers have a similar effect. Don't you worry. Anyway, so any questions from the first half? Everyone feel good so far? So the question had come up about adenosine with Wolff Parkinson White, and again, I don't deal with a lot with those patients, and so again, if you talk to an electrophysiologist, obviously, like they would have way more to probably expound upon. But the question of like using adenosine being contraindicated in Wolff Parkinson White, that's specifically a warning associated. We have AFib plus Wolff Parkinson White and using adenosine. That can lead to some issues with that, which I think is what you guys had learned in EKG versus just using it for WPW by itself, right? Because again, you want to be careful with nodal blocking drugs like a beta blocker for Wolff Parkinson White, because that's when the accessory pathway can kind of take over and set the pace. Versus adenosine is kind of globally just shutting down the heart. Because again, if you look at the EKG, like you've no electrical activity whatsoever, and then it comes back a split second later, right? So again, you don't have to worry so much about that in that situation. So hopefully that's clarifying for everyone. Anywho, getting back to it, we're talking about cap treatment. We're talking about, typically you can get away with the macrolide. Sometimes if you're worried about that strep pneumo, you gotta kind of increase your guns a little bit there. A lot of people's gut instinct, let's just go fluoroquinolone, one drug and we're done. Not necessarily. You want to hold back on those due to the resistance issues, due to some of the side effect profiles seen with that, right? Now, if you have to admit the patient, you want to stick with oral therapy? You want to go IV now? What do you want to do? They're already paying for the bed. Might as well give them the full court press, right? Let's go IV. Let's give them a little bit more better systemic coverage here. Typically, we like to use IV therapy. There are some notable exceptions with that. So, for instance, usually with macrolides, we still stay oral for whatever reason. IV tends to be more expensive, does not get used very frequently. So, if you're still using, even if you're getting, let's say, IV beta-lactams like ampicillin, or you're getting Zosyn or something like that, you still end up seeing patients on oral azithromycin unless they have a contraindication and cannot receive that. So, just a little point there if you ever see that. Anywho, they're coming in, say they're non-ICU, they're going to the floor, we can use an intravenous beta-lactam, right? So this is where we're going to use something like cefotaxime, ceftriaxone, a good third-gen cephalosporin there. We could use high-dose ampicillin. Potentially you want to use ampicillin, sulbactam. That could be a potential option as well, but usually just high-dose ampicillin by itself is good. So you want to use one of those plus an oral macrolide or doxycycline. Either one of those two would be fine, because again, those are going to get your atypicals. The beta-lactam is going to be able to get your strep pneumo, anything else from that standpoint, right? And again, if you could not use that, then you can switch over and try using a respiratory fluoroquinolone. Typically, that's going to be reserved more for those with strict beta-lactam allergies and they cannot receive cephalosporins, right? But again, how often is that going to actually occur? Not frequently. So again, hold off on those IV fluoroquinolones whenever possible. If you have to go ICU, everything should be IV as much as possible, but then you also have to consider MRSA. And what's our go-to MRSA drug? Vancomycin, right? Again, the IV go-to a drug for MRSA is going to be vancomycin there. Okay. Now, looking at community-acquired MRSA, was less frequent in the past, but we're starting to see it become more of an issue, especially if you notice that patients had a recent case of flu that could predispose them to getting MRSA. Any kind of lesions noted on cavitary lesions without a risk for aspiration, they also tend to be more at risk for that as well. And again, if you get the gram stain, there's a lot of gram-positive cocci clusters on there. That could also kind of key you in the, hey, maybe we're dealing with some staph here. Again, if vancomycin is not going to be possible, and who might vancomycin be a bad choice in? It's not many patients, but again, if they have a documented true allergy to it, or if they've potentially had, bad enough kidneys where they really could not tolerate the medication and you couldn't really get a good dosing pattern on them, linezolid might be a better option in those cases. Now, one thing I will say when it comes to pneumonia is that vancomycin has a hard time penetrating lung tissue. It is a very large molecule and has a hard time doing that. So when you're looking at things like the levels you're shooting for, and again, I'm not going to give you specific levels to memorize here, but just know that when I give you, like, I may give you a range on a test or something, but again, we have to shoot for higher levels. And the reason for that, and again, we're doing troughs or peaks with vancomycin. Doing troughs, right? Remember, it's a time-dependent antibiotic, so it needs to be above that MIC. We have to shoot for higher troughs in order to make sure that we can get a high enough level to penetrate that lung tissue. So, for instance, if I was treating a simple bacteremia, I can do maybe a trough of 10 to 15 mics per ml, and that's going to be fine. That's a good enough trough for that. If it's a lung issue now I got to bump it up to 15 to 20. It's actually the same dosing you'd be using if it was for something like meningitis, right? So again, think about the lungs being hard to penetrate for vancomycin, just like the CNS would be, right? If they could not tolerate that, then that's where linezolid or Zyvox is going to be a good option in those cases there. Now, you remember we talked about daptomycin briefly? Daptomycin cannot be used in pneumonias, right? The long surfactant actually will inactivate the drug. Cannot use it there, okay? So if I put daptomycin as an option for treating a pneumonia, you would say, no go, that's going to be not effective here, okay? Okay. Now getting into the nosocomial pneumonias, what does that mean? We gave it to them, right? So again, some kind of healthcare associated sort of pneumonia that they've now picked up, right? So again, this is something that was not present upon admission. And again, is this something insurance companies want to pay for? No, right? They said, well, that's your problem. You were the one who gave them the pneumonia. We're not going to cover that. And so that's going to be one of those things where, again, good infection control is going to be super important here, making sure that patients are being, hygiene is very important. People are washing their hands, etc. But typically this is considered after 48 hours of admission. Once they kind of pick this up, then that would be considered hospital-acquired or nosocomial pneumonia. Now, kind of the broader category here includes hospital-acquired ventilator-associated pneumonias, and then also healthcare-associated pneumonias. So this includes those that are like in an assisted living facility or something like that, where again they have providers who are going to be going from like patient to patient, and again they can spread all those nice bugs around, especially if they've got a lot of resistance developing from multiple antibiotic use. So kind of all of that kind of fits in the same category. Okay, and again it's very, very frequent. Second only to UTIs as far as nosocomial infections go, and a very high incidence in the more elderly patients and those especially who are mechanically ventilated. Why do you think it's a big problem in those that are mechanically ventilated? You have a big plastic tube going down their throat, right? And again, that's going to be a nice fomite for the bacteria to just travel down and get into the lungs, right? So again, that's where if you can get the patients off the vent, the better off that's going to be for those patients, right? The sooner you get them off, the better. But oftentimes you can't do that, maybe on it for weeks, months potentially. You just have to kind of deal with that and make sure you're using things like good oral hygiene. That's where frequently you have things like, chlorhexidine is a good antiseptic we'll use to clean the mouth to make sure you don't have any bugs kind of getting the respiratory tract from that standpoint. We'll also look at some other things as well in just a few minutes here. But big problem though is it's causing more mortality and higher hospital costs. Okay, so again, anyone that is considered to have a healthcare associated pneumonia is going to be those people that have been, like, say, hospitalized in acute care facilities. They may be greater than 2 days in the past 3 months. They're in that long-term nursing home facility sort of setting there. And again, we see a lot of those patients coming into the ER. They get sick over at the nursing home. They get transported over to us. And it's like, hey, here's a big old mess. Here you go. Figure out what's going on with these patients. Right? And again, oftentimes they're going to be septic, they're hypotensive, the kidneys aren't functioning, they got all these infections going. It can be very difficult to manage those patients. But recently, IV antibiotics, chemotherapy, why do you think that's a problem? They're immunosuppressed, right? So again, they're going to be picking up bugs that we can normally fight off with a good immune system. Wound care, kind of a similar thing there. Going to be more likely to see infection. And then also hemodialysis patients. Why do you think that is? Yeah, so kidneys aren't really functioning. We know with like chronic kidney disease, immunosuppression is kind of a thing you may see with that. Maybe not to as great a degree, something like chemotherapy, but certainly it's a concern. But also, what else do dialysis patients need to have dialysis? Yeah, they have big IV access. Usually have a dialysis catheter that's going to be in place or a port that's in place. And again, foreign material can be a source for the bacteria to grow and then spread throughout the body, right? Especially to the lungs. So the dialysis patient can be another big one. They get very, very sick from this. So, we'll talk about modifiable versus non-modifiable risk factors here. Obviously, modifiable just means stuff that we can change, things that we can do there, right? So, for instance, we can't deal with the patient's age. We can't help, change the patient's level of consciousness necessarily. But certainly, some things we can do are going to be things like, getting rid of any kind of external apparatus out of the patient. So we can get the ET tube out of them. That's going to be great. If we can get the NG tube out, etc. The one thing I do want to point out on here are going to be the H2 blockers or antacid therapies. Now, we haven't covered these in GI section yet. That's going to be for next semester. But an H2 blocker means what? What does the H mean there? Histamine, right? Because we talk about H1 blockers there. So this is like Zantac and things like that. Why do you think an H2 blocker, what would that do in the stomach, do you think? Histamine normally does what to stomach acid production? Increases it, right? You need histamine to form that stomach acid. It's one of the big stimulators there. If I had an H2 blocker, what's that going to do to stomach acid production? It's going to go down. Okay, that makes sense. All right. We're there so far. Antacid therapy, what's that going to do to the pH of the stomach? It's going to increase it, right? It's an antacid. It's going to be neutralizing those acids, like calcium carbonate, like Tums or something like that. So why do you think that would be risking or increase the risk for someone developing pneumonia? So work through it. So we got to have an increased pH in the stomach. Normally, do bacteria grow in the stomach? Not typically. Stomach acid is enough to eradicate most of that, except for what notable bug? H. pylori, that's able to survive in the stomach acid. But let's say we don't have H. pylori we're dealing with, but you're increasing the pH of the stomach. These bacteria all of a sudden can start to grow. Well, then what happens? They can aspirate, right? So then you have these bugs that are going to be aspirating into the respiratory tract, and then they can develop into pneumonia there, right? So that's a big concern we have with that. That's where things like oral hygiene can be useful to try to make sure we're trying to sanitizing the mouth. But why would we put a patient who's mechanically ventilated on an H2 blocker in the first place? Well, that goes back to these stress-induced ulcers, basically, right? So imagine all of you right now are chronically stressed, right? Your stress levels are through the roof right now. What's your cortisol levels like? Yeah, pretty high, right? Bajillion, as Kyle says. But very high levels here. And so what does that do to the stomach? Does it help make a nice protective barrier around your stomach? No, it's going to erode that, right? You're going to find that nice protective barrier is not going to be produced because guess what a corticosteroids like cortisol do to your prostaglandins? Suppress them, right? They can't form prostaglandins. Guess what prostaglandins were doing in the stomach? Forming that nice mucosal barrier. So that's gone now, right? So you have these critically ill patients who are mechanically ventilated. You kind of think about them being in the super stressed state. Well, we don't want them to get an ulcer forming there in the stomach, so we have to give them antacid therapy. There's also PPIs would fit in this category as well, proton pump inhibitors. And so basically we want to make sure that we're keeping them from getting a stress ulcer, but then we also have to make sure they don't get an infection from that, even though the treatment for one's kind of leading to the other. So you can see how these patients get more and more complicated, right? You have to use multiple drugs in order to treat the same things. Sometimes these therapies can be sort of a double-edged sword, okay? All that makes sense? So you can go back, review the basic physiology, and you kind of understand how these drugs are going to have these kind of downstream effects from there, okay? You have a question? So the H2 blocker is going to prevent the stress-induced ulcer, but it's also going to allow those bacteria to grow in the stomach because now the pH is much higher and can allow that aspiration to occur. Does that make sense?
Yeah.
Perfect. So anyway, yeah, and again, if you can, other things, previous antibiotic exposure also puts them at risk for this, reintubation, all those things. So again, try to manage the modifiable ones. Some of them we're not going to be able to deal with too much, but, again, the unmodifiable can't do a whole lot. So looking at the etiology for some of these nosocomial pneumonias, you see a lot of gram-negative bacilli here. So again, the most common one we are going to be covering for is going to be Pseudomonas, okay? And again, what did I say about coverage for Pseudomonas? This is where we're going to use double coverage for one particular bug here, right? Now, again, this is in stark contrast when we were talking about, say, for instance, coverage for community-acquired pneumonia with resistant strep pneumo being a concern, right? I used 2 antibiotics there. What's the difference? I was trying to cover for different bugs, right? So again, I was using the macrolide to cover for atypicals, but I used the beta-lactam for that strep pneumo. Here, we're actually using 2 drugs specifically to get one particular bug because the resistance can be so bad, and because if you leave it unchecked, it can be quite deadly. So that's one thing we'll talk about in a second here, but you have things like E. coli, Klebsiella, Acinetobacter, Serratia, all these gram-negative bacilli can be playing a role here, right? Again, you also have to cover for MRSA, right? You have to cover for a lot of gram-positive, but MRSA is the most clinically relevant one. And again, what are we going to use for that? Vancomycin is going to be playing a role here as well, right? Strep pneumo can also be present, but again, vancomycin should be able to get all those gram-positives for the most part. And then you also have to consider like fungal coverage, right? Again, could it be Candida, could be Aspergillus. Now, normally, do you think we're going to be covering for antifungals at baseline? Is it part of empiric therapy? Not typically, but it's one of those things where if you're administering empiric therapy to your patient, they're just not improving. White count's still sky high, they're still febrile, not improving clinically. Is where you have to consider, hey, maybe there's a fungus to play a role here. Maybe we need to add on antifungal therapy. Maybe we need to do a fungal culture to see if that's what's actually growing here, right? So typically start therapy as soon as you can. Again, we don't wait on a definitive culture, but get those cultures before antibiotics if possible. And so we're going to consider using broad spectrum antibiotics. Okay. Now we have to make a decision. Do we have to worry about multi-drug resistant bugs or not? And we'll look at some risk factors for that. If you do consider that there may be multi-drug resistant pathogens here, you have to cover for MRSA and Pseudomonas at a bare minimum. Again, that's going to be very broad empiric coverage. You're going to be getting a lot of stuff kind of included with that, as we'll see here in just a few minutes. And then once you have the cultures back, then you streamline therapy as best you can, right? So for instance, if you're giving them stuff and they're covering for everything and then it goes back MSSA, what could I use? Dicloxacillin, nafcillin, something like that, right? So again, you want to streamline your cultures based on what's coming back on those results there. So looking at this, say we have our healthcare-associated pneumonia that we're suspecting here. Let's look at the things that may put us at risk for having a multi-drug resistant sort of bug here, right? So again, looking at the previous antibiotics. So again, looking at the particular colonized. Now, when I say colonization, what do you think that means? It's like some British bugs that come over and they say, this is my land now. No, this is like, we have like trach patients or someone who's going to have, kind of chronically have these bugs growing and they're just kind of living there. They're just going to be there for as long as that patient's going to be trached. And, things like that. Cystic fibrosis patients can be colonized with certain bugs. So again, it's something that's going to be a concern for like specific population subsets. Previous hospitalization, if they're on chronic care, like nursing homes, things like that. Immunosuppressive therapy. Like, these are all going to be things that put them at risk for a multi-drug resistant pathogen. And then that's where you're going to need to broaden out your coverage in order to get those bugs there. Okay. So looking at no risk factors there, let's go ahead and start out with, say, a 3rd generation cephalosporin. So you can use a 3rd generation cephalosporin, or you can use something like levofloxacin or moxifloxacin. If you're more worried about atypical pathogens, if you work somewhere where you see that there's like a lot of mycoplasma, things like that more present, that's where you can use a fluoroquinolone instead here. Again, no Cipro, because you still have to think about things like strep pneumo being potentially playing a role here. Or you could use something like ampicillin sulbactam, which is what kind of drug? Penicillin plus beta-lactamase inhibitor, right? So again, that helps to broaden out that coverage, good. Or you could use something like ertapenem. If you remember ertapenem, what category did that fall into? Carbapenem, but what was the notable exception in coverage for that one? No pseudomonal coverage, right? So again, it is kind of the wimpiest out of all the carbapenems because it does not cover pseudomonas. But that's okay in this group because we're not really worried about covering for atypicals at this point. Or I'm sorry, we're not covering for pseudomonas at this point. So if they are positive for risk factors for a multi-drug resistant pathogen, this is where you got to step up your game a little bit, right? So this is where we're going to use 2 drugs to cover for Pseudomonas in general, those 2 drugs that cover for Pseudomonas are going to get most of your gram-negatives, and you're going to have 1 drug to get your gram-positives, particularly MRSA. Okay, so this means we're going to use either a anti-Pseudomonal cephalosporin. Anyone remember what that is? Ceftazidime could potentially be used, but we don't like that drug for Pseudomonas because it gets resistant very quickly. So we don't use that, but instead, what could we use? Cefepime. Cefepime is the go-to anti-Pseudomonal cephalosporin. How about an anti-Pseudomonal carbapenem? All of them except ertapenem, which includes imipenem, cilastatin, meropenem, some doripenem potentially you could use, and then or you could use anti-Pseudomonal penicillin beta-lactamase inhibitor, and the only 1 drug we have for that, Zosyn, piperacillin tazobactam. That's the big one there. So you're going to use 1 of those plus anti-Pseudomonal fluoroquinolone like levofloxacin or Cipro. And notice Cipro is okay here because we're using these beta-lactams. Those are going to get that strep pneumo. So at that point, I don't really worry about it. I just want something with anti-Pseudomonal coverage. So you could use something like Cipro here. That would be fine. Or you could use an aminoglycoside, such as gentamicin, tobramycin. What's the third one? Amikacin. Yeah, amikacin could be a good option there as well. So any 3 of those, or any 1 of those would be fine for the aminoglycoside, right? So you're going to need 2 drugs for the Pseudomonal coverage. So 1 of these 3 plus 1 of these 2. Okay. So again, you got to mix and match your options here. You have a lot of different drugs at your fingertips here, based on allergies, based on toxicities, based on all sorts of different things. Will help you to decide which one's going to be best for your patient there. In the plus, you want gram-positive coverage. 99 times out of 100, you're going to go vancomycin. Linezolid could also be used here as well. But notice daptomycin, you cannot because it does not work for pneumonias. It gets inactivated in the lungs. So looking at the anti-Pseudomonal cephalosporins, again, cefepime is going to be used here, maxipime. Now, I'm going to note here that most of these tend to be renally adjusted. Why do we care about that? Think about it, these patients are probably going to be pretty critically ill. If we think they have this resistance of a bug, they're coming from the nursing home, they're coming from somewhere where they're so ill, they're probably going to need to go to the ICU, they're probably going to need to be intubated. They're very, very ill, right? And so again, they can develop things like sepsis from this, right? They can have this spread of the infection where they're getting things like hypotensive, right? What happens when you're hypotensive? Where does the blood want to go to? The heart and the head, right? What kind of get put in the back seat there? The kidneys, right? Okay, so that means if I have someone who's developing the sepsis, they're getting hypotensive, they're not perfusing the kidneys very well, what does that do to kidney function? It's going to go down, right? So kidney function is going to go down. What does that do to my clearance of these drugs? It's going to go down, which means levels are going to climb. Maybe good for killing the bacteria. What else is it good for killing? Your patient. You don't want to do that, right? So again, you want to typically keep them alive and healthy as long as you can. So that's what we're trying to do here. So you got to look for the renal function. You have to monitor for that, right? And what do we say about the limitation of monitoring something like creatinine as a surrogate for creatinine clearance? Does the second you have kidney injury, does creatinine go up? No, it has a half-life just like anything else in the body. It takes time for it to get to a new steady state. What can you look at, though? It's a little bit faster. Urine output. You can look at urine output to see how they're doing, right? What's a typical, like a good urine output for an adult patient? Anyone know? I usually use like 0.5 to 1 mLs per kilo per hour, right? So if I have a 100 kilo patient, if they're putting 50 to 100 cc's out an hour, that's generally pretty good. They're generally shows they're getting rid of some of that urine there. You know, for a kid, 1 or above is going to be a good number from that standpoint. But you got to monitor for those sort of things because it's very easy for the kidney function to go down pretty precipitously. You don't monitor it closely enough, and then all of a sudden they're getting toxic from all the medications they're on. Okay, this is why I make such a big point about noting these. Again, anti-Pseudomonal carbapenems. Again, anything except for ertapenem is going to be on this list here because it does cover Pseudomonas. Again, we normally like to hold off on these as best we can, mainly because of the fact that, again, they are such broad coverage. We'd like to reserve these in case other things fail, right? So if we can get away with using something like cefepime, let's use that first and then use these as a backup if that fails, right? Because, again, what's kind of the difference in coverage between, say, for instance, meropenem plus or meropenem versus cefepime? Yeah, what's the difference? Yeah, anaerobes is a big thing, right? So cefepime does not cover anaerobes. All of your carbapenems do cover anaerobes, right? So good anaerobe coverage. So again, this is even wider coverage than cefepime would be. So again, another reason why I like to hold off on these. And remember, depending on where you work, you may find you may not even have access to these, right? You think, well, I'm the prescriber, I can prescribe whatever I want. Not necessarily the case, right? So you may have things like antimicrobial stewardship programs that say, no, you got to get the approval of the infectious disease doc before we'll even let you have access to it, right? And again, that is done for the benefit of, you know, not only your patient, but the society as a whole, to make sure we're trying to put reins on these things to try to limit that resistance there, right? Again, benefit of using meropenem, less seizures than you see with imipenem. Again, that's going to be a problem, especially with patients with seizure history or renal dysfunction. And again, any of these have to have renal dose adjustments, so watch for that. As far as anti-pseudomonal penicillins, we have piptazo. Tickeracillin clavulanic acid is not used very frequently, so don't really think about that one too much. But piptazo is obviously going to be our go-to here. And again, does this cover for anaerobes? Yes, it does. Yeah, so Zosyn will also cover for anaerobes. Again, it's another one we like to hold back if possible, if it is therapeutically appropriate. Again, requires renal dose adjustment. Getting into your anti-pseudomonal fluoroquinolones, this is where things like ciprofloxacin, levo are probably the two most common ones you're going to be going with. Guess what you have to monitor for? Renal function, absolutely, because again, you got to watch for this. Otherwise, you're going to be accumulating drug. It's not going to be good. The nice benefit with these, they have good coverage against the atypical bugs. So if you're worried about Legionella, Mycoplasma, anything like that, it's very good from that standpoint. And they have pretty good lung penetration. However, a lot of bugs, a lot of Pseudomonas tend to be resistant to the fluoroquinolones. We cannot get much use out of this. Okay, so you have to follow things like your antibiogram to see how often Pseudomonas is actually susceptible to things like Cipro or to levofloxacin. If it's something like 70%, versus I can look at something like, say for instance, gentamicin is 98%. Which one are you going to use in that case? Gentamicin is much more likely for it to be actually susceptible to that. I don't want to use something that only has, say, a 3 in 4 chance of actually working for my patient. So this is where things like antibiograms can be really useful here. Pneumonoglycosides, what do you have to watch for? Oh, yes, sir.
For Zosyn, did you say that covers anaerobes too?
It does, yes. Zosyn does cover anaerobes very, very well. Getting into aminoglycosides, again, we have Gent, Tobra, and amikacin here. Now, one of the things we've done in recent years is actually going from a Q8-hour dosing to just one-time daily dosing. This gives us the ability to give a really big dose up front and then to kind of clear it as they go along. And usually every 24 is going to be good enough for most patients. They do have renal dysfunction. This is where you have to extend it out even further. So you may see Q36, Q48-hour dosing and spaced off of that, right? Because we monitor the trough. Here, we don't monitor the trough to make sure that they're above the MIC. We want to make sure they're actually clearing the drug. So in the case of like vancomycin, I'm shooting for a trough, say 15 to 20. Here, I wanted a trough that's undetectable. That shows me that they're clearing it out of the body and they're ready for their next dose, essentially. Okay. But again, we shoot for bigger doses. Another big thing with this, the higher concentrations we get, the better lung penetration we're going to get, which is a nice benefit there. But again, watch for nephrotoxicity, watch for the ototoxicity, right? And again, if your patient's intubated, sedated, are they going to be able to tell you, hey, I'm hearing's getting a little fuzzy in my left ear? Not going to tell you that, right? So again, you have to be monitoring the levels because that's going to be used as your surrogate marker for that. And then vancomycin, as I mentioned, we like to shoot for higher doses here to make sure we get good penetration. And it's going to be good for MRSA. Okay. Again, similar to the aminoglycosides, though, look for ototoxicity, look for nephrotoxicity. Okay. What's the other big thing you have to think about when you're administering vancomycin to a patient? Yeah, slow it down so you don't get red man syndrome. Minimum hour and a half, 2 hours, you're going to be administering this drug over that time frame for, right? Zyvox, very good for MRSA. Typically, we will like to hold this back if the patient has a documented VRE or vancomycin-resistant enterococcus, or if they develop like a VRSA, a vancomycin-resistant Staph aureus. This is where we're going to be using something like Zyvox most often. The big benefit with this one, though, do I have to monitor renal function? Nope, I don't have to do that, right? So this again was one of the notable exceptions where I do not need to monitor renal function. I can give it kind of with impunity in those cases there, which is nice. But pretty expensive. Again, another one of those ones that will typically be reserved for the either documented susceptibility, resistance to other stuff, or if the patient cannot tolerate something like vanco. Okay, so again, once the cultures come back, you can scale back your therapy at that point. Now, whenever possible, we like to switch over to PO. What's the benefit of PO over IV therapy? Maybe you could leave the hospital, right? So that's definitely one of those things that get you on the road towards being discharged, right? Is it cheaper? Yeah, it's a lot cheaper. Again, it's a lot cheaper for a nurse to give a patient a pill they swallow versus having to use the IV, right? Well, what about from an infection standpoint? Yeah, you have less lines. So again, if you can DC those peripheral IVs or a central line, less likely to develop infection, right? So again, it's another big benefit of getting patients off their IVs whenever possible. Now, if the patient's failing therapy, you're giving them the full court press, they got on three medications, cultures come back and they got nothing on there, nothing grows back. Patient's not improving at all clinically. What do you have to consider? Well, was it the wrong therapy, right? Maybe it was the resistant pathogen, my antibiotics not treating well, or maybe I have inadequate therapy. So maybe you only did one anti-pseudomonal drug instead of 2. Yeah, it could be one reason. Perhaps the wrong diagnosis, right? Maybe you missed it was actually, something like cancer. Maybe it was something like, pulmonary embolus that was causing these symptoms, right? Maybe unlikely. Hopefully you've kind of worked them up from the full medical standpoint, instead of just pigeonholing them into pneumonia, but it could be something going on there. And then you have to consider things like complications. If they develop C. diff, what am I going to give them? Oral vanc. What if they're already on IV vancomycin? Yeah, so you can find patients who are on IV vancomycin plus oral vancomycin for C. diff infection, okay? Again, therapeutically, it looks like that would make no sense, but it does make sense because, again, vancomycin is a very large molecule. It does not get into the GI tract to really treat that C. diff infection. What else could I do? Yeah, what if they could not receive anything PO? Yeah, you could use IV metronidazole. So that's the case we use IV metronidazole to treat a C. diff infection. In some cases, we can actually do rectal vancomycin enemas. So you can do like a retention enema occasionally. That's less commonly done because most of the time we can either get it with IV or oral therapy in those cases there. Okay. Anyone know what another cool, I guess not cool, but interesting way to treat C. diff? Fecal transplants. Yeah, you actually get some people to live with them to donate some of their feces and then say, if you really give a crap about me, you'll do this. Yeah, so anyway, so you can do fecal transplant and hopefully get kind of restore the normal gut flora that a patient was normally kind of exposed to. I know, we got into the dirty talk and everyone's getting a little chatty. Bring it in. Shh. Shh always works. Typically, as far as therapy goes, duration-wise, 7 to 8 days for most patients. However, longer if you're dealing with one of these more nasty bugs like Pseudomonas, Acinetobacter, Burkholdeus cepacia, Stenotrophomonas multifida. Any of those typically require a little bit longer therapy, at least 10 to 14 days. Okay, so any questions on pneumonia? Fantastic. Let's move into talking about tuberculosis. So what is tuberculosis? Have you covered tuberculosis? Huh? Yeah, so infection caused by Mycobacterium tuberculosis, right? So again, there's lots of different varieties that are going to be out there, but it's acid-fast bacilli. Is this a very fast-growing or kind of slow-growing bug? Very slow-growing, right? So what you're going to see with pneumonias versus TB as far as like durations of treatment go, what's the difference? TB is a lot longer. There's going to be months long of treatment that we're going to be focusing on here, right? So, and one of the problems is that they're very difficult to treat because they have this nice kind of waxy cell coat that they'll kind of form around themselves. They make it hard for a lot of our antibiotics to actually penetrate into. The other big thing, and again, the one we're going to focus on mostly here today is Mycobacterium tuberculosis, is very slow growing. It can kind of form those dormant states, right? They can just kind of live in the lung for a while before they really kind of germinate out and actually form, fulminant infection there. And again, if what you're finding with a lot of the antibiotics we're using, like especially if they're focusing on things like cell replication, like protein synthesis or DNA synthesis, if they're not rapidly dividing, you're going to find they don't really do a whole lot of good on those spores there. So because of that, it's very, very difficult to treat. So again, you have a whole host of diseases here. For instance, you see things like Mycobacterium avium complex. Anyone know what patients you see those in? Yeah, HIV patients. That's one of those AIDS-defining illnesses. So if you develop a MAC infection, that's considered to be you have AIDS at that point. Things like leprosy, all kinds of different infections that can be developing from these mycobacteria. Now, I'm not going to cover all of these. I'm mainly just going to talk about tuberculosis, but a lot of the drugs you may see some cross coverage there because they'll be able to treat multiple different types of mycobacterium. So looking at this, and we'll go into the specific drugs because most of these are new here, we're going to see that typically you start off with kind of a 4-drug regimen here for about 2 months or so where you're doing things like isoniazid, rifampin, ethambutol, and another one called pyrazinamide. Again, the doses are not important to memorize here, but you can get an idea of how the treatment's going to be going. Start off with a 4-drug regimen, and you follow it up by 4 months of a 2-drug regimen of isoniazid and rifampin. So you kind of hit it hard at first for 2 months or so, and then you can kind of scale back therapy a little bit from then on. Okay. Now, what kind of patients do you think are more likely to get TB? Like immunocompromised patients could be one. Who else? Homeless patients, IV drug abusers, things like that. So again, what do you think about compliance? Not going to be great for a lot of these, especially if you had a patient who cannot really provide for themselves from a socioeconomic standpoint. You're saying, hey, I got to take these medications for like 6 to 9 months. Like it's not going to happen, right? So this is where things like direct observed therapy is going to be really important to make sure that these patients are actually getting their doses like they should. But again, looking at this, depending on things like if the disease becomes more complicated, if they have HIV, the therapy can go up to 2 years in some cases. So again, very difficult to get patients to be really compliant with these regimens here. And again, we don't like to use just single agents because the chance for resistance goes up pretty astronomically anatomically at that point. And again, what's the problem? Say you have a homeless patient who is, say, starting therapy. They do it for, say, 6 weeks, and they decide, I'm going to get off of it. I'm done. Resistance, right? So again, inadequately treating these oftentimes will lead to resistance as well. So first off, we have isoniazid here, and so this one is going to be, and again, to kind of see how depending on the phase of its latent versus active disease, isoniazid can be bacteriostatic versus bactericidal when it's actually actively dividing. Basically, this one's going to be working to try to inhibit that waxy coat to allow a lot of our other medications to get in there and be a little bit more effective in these cases. Now, just like we saw with things like procainamide, and just like what we saw with hydralazine, this one is also metabolized by acetylation. Acetylation. Think slow acetylators. What can they develop? Lupus-like rash. That's going to be another one. We're going to see that become an issue there, right? Again, you can see how a lot of these can be, TB can develop resistance to it over time. They can do things like mutating their DNA, coding for different enzymes, etc. If it doesn't get activated within the TB cell, then it's not going to be able to be effective there. So you can see how these bugs can be resistant over time. Now, as I mentioned, isoniazid can sometimes be used for prophylaxis, before the disease actually occurs, or oftentimes an active disease where you see the combination therapy here. As I mentioned, look for these kind of allergic-like symptoms, that lupus-like rash that is most commonly in those slow acetylators. And it's hard to predict who's going to be that patient, but when they manifest it, you want to know that's what's going on there. Okay. This can also be hepatotoxic as well, so you have to be careful with alcoholic patients. And again, what might a homeless patient be? Alcoholic as well, right? So you have to monitor their LFTs to make sure that's not going to be an issue there. And then also, it's kind of interesting is that isoniazid itself can actually impair the ability of the body to use pyridoxine or B6. And so what that can manifest as is a kind of a peripheral neuropathy. So it usually has kind of a stocking glove sort of distribution where it's going to be affecting kind of the distal ends of the extremities first. So you get kind of the fingertips and the toes, you get this neuropathy that develops and can kind of travel more centripetally at that point. But so that's why very frequently we'll give isoniazid along with B6 to try to stave that off and try to prevent that. And what's kind of interesting as well is that one of the things you need to produce GABA in the CNS is actually pyridoxine. If you don't have that, you can't convert glutamate. Which, glutamate is what in the CNS? It's excitatory. It's like the gas in the system, right? So, you cannot convert that over into GABA. So what do you think would happen if I had someone that had too much isoniazid on? They can't convert all that glutamate over to GABA and have too little GABA and way too much glutamate. What can develop? Seizures. Yeah, seizures are going to be the big thing there, right? So you see a lot of excitotoxicity, seizures, euphoria, memory impairment. All those things can be developed in here. So again, it's one of those things where is that, did the patient have a mental illness issue? Is that getting worse, or is it just due to the fact that they don't have enough B6 in their system? They develop full-on seizures. This can be one of the big reasons for that, right? So next up we have rifampin. We've talked about this a little bit in terms of what? Remember with endocarditis, right? We talked about that as being one of the last drugs you add on. Something like, say, you could do like a PNG plus gentamicin plus rifampin. You got a 3-drug regimen. It's good for helping to shorten up that duration of treatment there. Why do we use rifampin last in that case? Because the resistance can develop, right? So that's why you add that one on last here. Again, pretty broad spectrum, but we don't like to use it by itself for many disease states because, again, the resistance patterns are such an issue. However, this is going to be good to inhibit that RNA polymerase. It's going to help to prevent further replication of the TB cells there. And again, you're going to find this very frequently used for TB by itself. You used to see it more with prevention of meningococcal disease as a prophylactic. That's not used quite so frequently anymore. Nowadays, Cipro gets used more commonly. And as I mentioned, endocarditis is the other big place you see it being used. Remember the big drug interactions you see with rifampin? CYP3A4 inducer, right? So this is one of the first CYP3A4 inducers we've actually seen here. It can affect some other enzymes as well, but 3A4 tends to be the most clinically relevant one we'll see with that. And again, can affect all sorts of things, anticoagulants, oral contraceptives, digoxin, theophylline, all those things can be affected by these drugs. So you got to check these interactions beforehand, right? Again, you see some liver dysfunction you can develop here. And remember the color of rifampin? Dark red, right? So again, it can stain the colors of all of your secretions. Be kind of this orangish kind of discoloration, right? It's really dark red when you take the tablet or the capsule or the IV form, but then it kind of gets diluted out and looks very orangish when it comes out in the secretions there. Again, some patients develop kind of a flu-like syndrome with this. So again, a lot of side effects associated with this. So you think someone's going to want to take this for 6 months, 12 months? No, they're not really going to want to, right? Because again, the side effects tend to be pretty nasty. Another one here, we have rifambutal. or ethambutol, I should say. This one, we don't really know why it's working or how it's working, but we do it's trying to inhibit that mycolic acid incorporation into the membranes of TB to prevent it from further replicating. So it's bacteriostatic, not cidal, but it's okay when you're using it in combination with many of these other drugs here. Okay, and again, this is also trying to kind of inhibit that cell wall a little bit to try to make it easier for other drugs to kind of get in, which is why you're seeing it used in kind of that early phase there, where you're trying to get that initial 4-drug regimen on board to really try to hit it, try to knock it down initially. Now, again, watch your renal function with this one, because again, that does have to be adjusted there. And one of the interesting things here you see is that it will cause a decrease in red-green discrimination, kind of a unique side effect with that one, where you may have some visual disturbances, where they may, it's almost like kind of color blindness to some degree there, and decreased visual acuity. So kind of a unique thing you might see with that one. And then the last drug here is going to be pyrazinamide. This one is going to basically lower the pH of the bacteria so it actually can't grow any further, and kind of helps to facilitate macrophages from coming along and kind of chomping up the TB itself. And again, by adding this on, you can decrease that duration of therapy somewhat significantly there, which is good. Again, hepatitis, liver dysfunction is going to be a big problem with this. Again, look out for those alcoholic patients. And again, this is not a good one for pregnancy. It can cause some teratogenic effects. Sir.
I think that we were taught that we were supposed to use this one for pregnancy and not to use the streptomycin.
I'd have to double check. There might be like specific areas in pregnancy where you're not going to use it. Hopefully you don't have to use this in any pregnant patients, right? But again, I don't deal enough with that to. I'd have to double check and see what the details are.
I think it said it was like if it was super resistant and they're pregnant, you could use this one.
Okay. I have to look. I don't deal with a lot of pregnant patients to begin with. Most of mine are. Hopefully I don't deal with too many pregnant patients at no mores, but never say never, right? Yeah, but again, the nice thing though is, guess what? Look up the guidelines. Go and like to look up to see, like, there's usually special populations, but they'll tell you, hey, this is what you should be doing. And again, Lexicon, if you're going to look this up, it'll tell you specifically what are the actual risks associated with it. It's easy enough to say, hey, this is a B, this is a C, it's a D. However, when you look into more specifics, they'll say, like, these are the studies. Did you find something over there? You're announcing your findings. But what does that say?
I looked up the lecture and it says it should be used in pregnancy only if resistant to the other antibiotics.
Yeah. So again, it's gonna be one of those things where you have to kind of make a cost benefit, or not cost benefit, but risk reward sort of thing to say, okay, this is gonna be a good drug for that patient or not. But again, you're gonna be looking this stuff up beforehand, or at least if you deal with this pretty frequently, you'll have a pretty good handle on how to manage those patients. Anyway, so again, if you do have documented resistance to things like isoniazid or rifampin, this is where you can sometimes use some of these other agents. Again, extending the treatment out, say 18, 24 months. Potentially have to worry about things like streptomycin, which can be a pretty nasty drug from auditory vestibular sort of toxicity. You can see with that. Again, I'm not going to get into big detail on a lot of these unless you kind of talked about them for other things. But just know the most common drugs you're going to run into is that 4-drug regimen. Pyrazinamide, ethambutol, isoniazid, rifampin, and then you go down to the 2-drug regimen afterwards. Okay, any questions on that? Getting back to something I know a lot more about and I like a lot more. This is like, I like the ER stuff a lot more, right? TB is like infectious disease, not my thing. Anaphylaxis though, I'm all about that, right? So what is anaphylaxis? Severe allergic reaction, right? So why do we care about it? Block the airway, right? So again, we see airway edema happening here. We're going to be blocking off the airway. What else about the cardiovascular system? Vasodilation leading to hypotension, hypoperfusion, shock, right? So these are the things we're going to be focusing on here as far as management goes, right? We talked a lot about these drugs already, but again, we're getting more detail on how we're going to use them specifically here. Again, what can cause anaphylaxis? All sorts of things, right? So again, it could be animals you're exposed to, drugs. It could be chemical irritants, anything like that could be a potential trigger here. But again, most often you think about things like a patient was out and they didn't realize there's peanuts in their food that they were eating or something like that, right? So again, you see these patients present all the time to the ER. So Again, you guys seem familiar with the signs and symptoms. I'm not going to belabor those points as well, but again, this can be the whole spectrum, right? So it can just be as simple as, you know, a minor bit of rash, some itching, all the way up to the full-on like airway closure. You know, patient's going to die unless I give them epi right this second, right? So again, there's a lot of shades of gray there, and so how you decide to treat that is going to be dictated by kind of what they're presenting as and how severe they are in their manifestations here. Okay. Again, the big question you always want to ask as well is when you have these patients coming in, especially to the ER, is what do they already get? Okay, so that's another really big bit of history I may not think about. So what did EMS give them on the way in, right? So again, very frequently EMS, when they drop off the patient, are they done for their day and they can just sit around, not really do much? Not frequently. Oftentimes they have to go out and go do the next call, right? So you want to make sure you grab them, make sure you get a good idea of what was actually given en route to make sure you know what they got beforehand, or who is most likely to develop anaphylaxis. Well, people with previous allergic reactions, what do they often get prescribed? An EpiPen. So you want to know, did they already get an EpiPen? Like, did they already give themselves the EpiPen before they actually got presented to the ER? These are questions you have to find out, right? And definitely for these patients, what are you going to ask them? What are your allergies, right? Exactly. Fantastic. Now again, can you have patients that are allergic to things like even endogenous products like epinephrine? Someone who's an epinephrine allergic? Get someone who's insulin allergic? 100%, absolutely you can, right? Sometimes it's not just the drug that they're allergic to. What else could it be? What is the drug formulated with, right? Is there a dye that's in the product that could be having a reaction to? In the case of epinephrine allergy, I would say, well, that's silly because you're producing epinephrine all the time. You can be allergic to it, but sometimes it's a preservative, like a sulfite preservative in there. So if we use preservative-free epinephrine, they don't have any problems. So again, sometimes you got to dig a little deeper into these allergic reactions to figure out, well, what specifically are they having a reaction to? Not just asking like, what was your reaction, blah, blah, blah. Because again, you may think, well, I can never give them epinephrine. They're coding, I can't give them epinephrine. No, you can. You got to get the right kind of formulation there. Okay, so things to think about. Anywho, so let's look at the stuff we're going to be giving them to try to kind of correct these manifestations we're seeing with this. Yes, sir. No, I was saying that if you had someone who said, I'm allergic to epinephrine, all of a sudden they go down, they're coding, like you can't say, I'm not going to give them epinephrine. You got to make sure you're like, okay, well, what was that reaction? Let me give them the right kind. Let me go find the preservative-free stuff, right? You call the farm and say, hey, this is what I got. Can you send me some down? And they'll give it to you, right? Because again, you know, it may be not have as much around, may not have it available. These are things like logistical things you have to think through when you have a patient that presents like that, right? It's not common, but it's one of those things where you may have to deal with it. And in the heat of the moment like that, where you need to give epi, chances are you don't have a lot of time to sit around and kind of ponder these little things like, do I have, you know, you need to act on it quick, right? You can perseverate and ponder after the fact, but they need epinephrine. Like a patient presents like this, they probably need something pretty quick, right? Because again, that airway, once you lose that, what do you got to do? You got to crank them, right? So you don't want to do that. So oftentimes we had these really severe patients who were coming in, and if like the residents weren't really sure if they were going to be able to get an airway or not, they just like bring out the crike kit. It actually kind of like a ward away against the bad juju, and that way they would make sure that, hey, if we just bring it out, we have it available, we'll never have to use it, right? So kind of was like Murphy's Law kind of thing. But anyway. So let's look at the stuff we're going to be using to manage these patients. One of the big things is going to be volume expansion, right? We mentioned what's happening with their blood vessels. They're vasodilating, right? So again, the pressure is going to go down. How can we fix that? Tank them back up, right? So again, the issue is not necessarily with the heart, because again, they're going to come in, they're going to be hypotensive. What do you think the heart's going to be doing? Going to be tachycardic, right? Because again, they're going to be trying to increase that cardiac output. They may not have enough to actually prime the pump those. By giving them volume expansion, we can try to fill them back up and get that pressure back up. So it's one of the first things they're going to be getting, in addition to things like epinephrine, which we'll talk about in a second. Now, what are we going to use to tank them back up? IV crystalloids. When I say crystalloids, what does that mean? It's also the alien race in my upcoming science fiction book I'm going to be publishing on Amazon. So it just means that it's going to have a salt-based solution, right? So crystalloids means like D5NS is be considered a crystalloid. You know, lactated ringers is considered a crystalloid. It's all salts-based, basically. Not necessarily just sodium, but just other types of salts. So when you think of normal saline, what do you think of? 0.9% sodium chloride. That's basically what the other name for it there. So again, when they're having vasodilation or having hypotension, this is where we're going to tank them up with IV crystalloids. Okay. The other stuff out there we can use like albumin, head of starch, and things like that. But no, let's just stick with the easy stuff. Go normal saline. It's going to be readily available anywhere you go. Okay. So remember, did we talk about this dosing before? I think we did in peds. So I'm bringing it up again because I think this is really important. Just kind of baseline dosing you should have at your fingertips ready to go. Because again, if you can go into the ER setting on your rotations, you can know how to dose fluids off the bat, you look like a rock star, right? So you want to know this kind of thing. So initially, again, this can apply to peds or adult patients, but for kids, you can use a round number of 20 mLs per kilo. 20 mLs per kilo for a fluid bolus. That's what they're going to get initially. And again, the thing with fluids is, if I give it, can I take it back? If I dialyze them, maybe I have to give them a bunch of Lasix, but it takes time. I'm not going to do that. You can always give more fluids if you need to, okay? So again, you're deciding how much to give based off how severe they're presenting, but again, you can't really go wrong in these sort of cases by doing 20 mLs per kilo. Generally, it starts off with a liter. An adult patient may go up to 2 liters depending on their size, right? So 1 to 2 liters for adult patients is typically pretty good. Now again, really severe case, you may need 4, 8 liters. That's no problem, right? That we can certainly see patients that can handle that when they're having this kind of profound vasodilation. Now, how do you do the maintenance fluids afterwards, right? Because again, you don't want to just fill them back up, but you want to make sure you're kind of replacing anything that's being lost in the meantime, right? So what do we use? 4-2-1 rule. How do we use that? 4 mLs per kilo for the what? First 10 kilograms of their weight. That's mLs per hour you're going to get from that. For the second 10 kilos, 2 mLs per kilo per hour. Good. And for that every subsequent kilogram, 1 ml per kilo per hour. Okay. So if I have a 60 kilogram patient coming in, 40 mLs per hour plus 20 mLs per hour plus 40 mLs per hour, right? So again, kind of go through those, kind of be able to practice a little bit. I guarantee there's probably going to be at least one question on your test. It's going to be looking at, okay, what's the right bolus dose and what's the right maintenance rate for this size patient? Okay. You know, it's not hard math, but you just got to do it a couple of times to make sure you're kind of confident in the results you're going to get there. Okay. Now, when you think like typical maintenance rate for an adult patient, what do people think of? Anyone have an idea? Typically do like 125 mLs an hour, but you could use a 4-2-1 rule for an adult. That's no problem. You get pretty similar results to that. But if you think about, if you hear maintenance rate, like 1 times maintenance or 1.5 times maintenance for adults, they're typically talking at a baseline of 125 mLs per hour. So if you hear 2 times maintenance, they would mean what? 250 mLs an hour, right? So you may hear that every once in a while, but that's typically what they're referring to. Okay, so let's do another 10-minute break. We'll come back and continue on. Actually, I only got 5 slides left. Let me finish this section up. I'm so sorry. I got your hopes up, but let me finish this up and then we'll keep going. Epinephrine. What do we give epinephrine for? Well, it's going to be this endogenous catecholamine. We know it's going to be affecting beta receptors. We know it's going to be affecting alpha receptors, right? So what does that do for our blood pressure? It's going to increase it, right? It's going to squeeze on the blood vessels there, right? What's it going to do, say, the bronchial smooth muscle? It's going to dilate it, right? So again, we're causing bronchodilation, we're causing vasoconstriction. All those are going to be good things to help reverse kind of the most dangerous sort of effects of this anaphylaxis here, right? It's going to decrease that edema. It's going to hopefully retain our airway as best we can. And so it's going to be very good from that standpoint. So it's going to help with the angioedema, help with the urticaria. All that good stuff is going to be helped manage with that epinephrine there. Now, again, as some of you correctly identified, most patients who have a history of anaphylaxis will get an EpiPen. Okay. Now, EpiPens are given via which route? IM, right? IM is always going to be kind of your go-to way to administer epinephrine for anaphylaxis. You do not give IV unless the patient's like legit coding, or unless you have some very specific circumstance where you need to. Typically, for anaphylaxis, epinephrine is going to be given via the intramuscular route. Okay. Now note that there are a lot of different ways to express the concentrations. There's 2 big ones you can run into in the hospital setting. There's a 1 to 10,000 concentration and 1 to 100,000. I'm sorry, 1 to 1,000 concentration here. Nowadays, they're moving more towards a more standardized sort of concentration where they just give you 1 milligram per ml or 0.1 milligram per ml, but just be very careful and make sure you know which one you're dealing with. Because what's the problem if I give the wrong concentration? Either give a 10-fold underdose or I give a 10-fold overdose, depending on which route I'm giving it by, right? If I give the 10-fold overdose route via IV, I can cause them to stroke out. Typically not great if they're coming in for anaphylaxis, causing them to give them a stroke, right? If I give them an underdose, what happens? They progress to still be hypotensive. They're still going to lose their airway. They're going to continue to get closer to that coding sort of scenario there. So be very careful. Just know there's multiple concentrations out there. Too much, you're going to see hypertension. You're going to see that anxiety, the tachycardia. So you're going to see all those kind of things associated with activating the sympathetic nervous system, because that's what it's doing essentially. Now, again, when you have a patient who's like having true blue like airway edema and they're having stridor, that kind of inspiratory wheeze, they're looking at severe, epinephrine is going to be the first drug they're going to get. It's very fast acting. That's going to be by far and away the most effective drug they're going to get right initially, okay? Now, if they're not having all those symptoms, they're not looking that severe, you don't have to give them epinephrine, right? Again, it's going to be kind of dependent on your kind of clinical gestalt, like how sick is this patient really? So if you don't need to give the epinephrine, there's a host of other drugs we can give to help manifest or help to manage those symptoms they're developing here. So for instance, we have histamine blockers. Now, what do you think is more important in this case, giving an H1 blocker or an H2 blocker? H1, because we know that's going to be the thing that's going to be mostly associated with a lot of these allergic symptoms. Do you think we want to use a first generation, a second generation? We're going to use a first generation. We want this stuff to be as potent as possible. We're going to get it all over the CNS and then the rest of the body. So we're typically going to use things like IV H1 blockers. And so anyone know your kind of go-to for that? Benadryl is probably the #1 go-to. You know, something like, you know, some other agents out there you could use, but this is going to be the go-to. It's going to be diphenhydramine or Benadryl here. And so this is going to be good because it helps relieve the rash, pruritus, the hives. If you're using oral, they maybe were not that severe. They need IV. This is where something like, you know, hydroxyzine or Atarax can be used in those cases there. And then potentially you could use H2 blockers like Zantac or ranitidine for the kind of gastrointestinal side effects. So it's not mandatory they have to get an H2 blocker. They're almost always going to get H1, but you can give H2 to help with the GI stuff. And then in the meantime, we have things like bronchodilators that can be used. We're going to talk more about this in the Pulm 2 section. We're talking about asthma, but this is good if you don't have IV access and you just need something to kind of work as a bronchodilator. So kind of keep that in the back of your mind. We'll talk about that in just a few minutes in the next section. However, the big thing I want to focus on here is the corticosteroids. Now, when you're looking at the corticosteroids, how are they working? You're getting down to the site of the nucleus to actually change gene transcription to decrease inflammation, right? So these are the most potent agents we have. However, are they going to work the fastest? No, these are going to be the slowest out of the bunch, right? So it's, you know, it's always kind of funny whenever you have like somebody who's coming in true anaphylaxis and they're like, we got to get the steroids right now. I'm like, let me get the epi first. Like the epi is going to save their lives right now. The steroids can wait a few minutes, right? So it's one of those things we want to get it on, but it doesn't have to be right that second, right? Because it's going to take some time to kick in, at least a few hours. Typically, you can get away with using, if it's, you know, a less severe reaction, you can use oral corticosteroids, but more often than not, for those more severe cases, IV is going to be the way to go here, right? This is where things like, you know, methylprednisolone can be used, prednisone can be used from an oral standpoint, dexamethasone is fine. Any of those corticosteroids are going to be good because, again, they're going to work systemically to decrease that inflammation, and then from there on, they're actually going to be able to prevent recurrence of effects because they're going to be sticking around for a while. So again, they may get the one dose of epinephrine to deal with the kind of acute life-threatening issues, but they'll be on the corticosteroids for a few days in order to help decrease that inflammation kind of going forward. That make sense? Okay. So again, thinking about if I were to ask questions on a test as far as anaphylaxis goes, say, hey, patient comes in, they're having some mild itching, you know, which medication are you going to give them first line, right? And I'll put, you know, something like, you know, I'll give you the vital signs. Vital signs all look fine. They're just having some itching. I'll give you like epinephrine. I'll give you prednisone. I'll give you, say, Benadryl, and then, I don't know, fluids. Like, what do you think would be the first one to go to? Benadryl, right? That makes sense, right? And again, I'm going to make it very clear cut. It's not going to be like, you know, very kind of gray because I don't believe in tricking you guys, at least at this point. Sims will trick you all day long. But at least for these, like, this is where we need to be clear cut on the test. So again, if I say someone's coming in and they have, you know, inspiratory wheezing, they feel like their airway's closing up, they're hypotensive, what's the first thing to give them? You're going to say? Epinephrine, right? Good, but fast. What's the fastest acting medication? Epinephrine. The slowest acting? Steroids, right? But again, those tend to be the most potent overall if you look in the long term. Okay, so those are things to kind of consider. Okay, any questions? Okay, go take your break. We'll come back. Continue on.